30 and the attendees are rapidly entering.
Okay.
My apologies in advance. I've trimmed your introduction a little bit just to leave you enough room to actually talk to us. I would like to welcome Dr. David Saraf. He's a clinical professor of ophthalmology at the Stein Institute at UCLA and a member of the Retinal Disorders and Ophthalmic Genetics Division. He has published over 300 peer-reviewed research papers, case reports, and reviews, and has also authored 22 book chapters. He is a world leader in the field of advanced retinal imaging and has delivered over 350 invited lectures at meetings worldwide. Dr. Saraf is Associate Editor for the British Journal of Ophthalmology and Ophthalmology Science and Section Editor of the Ocular Imaging Section for the Canadian Journal of Ophthalmology. He is also Section Editor for the Retina Times, the X-Files of ASRS, the American Society of Retina Specialists, and has served on the BCSC, which is of course the Basic and Clinical Science course section of the American Academy of Ophthalmology, and has actually been awarded several achievement awards by the AAO for his work. Dr. Saraf is also co-director of the Pacific Retina Club and the International Retinal Imaging Symposium and founding board of trustee member of the International Retinal Imaging Society. Dr. Saraf's focus of research interest is in the field of advanced retinal imaging. He's been a pioneer in the clinical application of OCT angiography and is a world expert on OCT and OCTA imaging of the macula. He has applied these technologies to better understand the structure and arrangement of the retinal capillary plexus and the ischemic cascade in occlusive retinal vascular disorders, and to gain insight into the pathogenesis and progression of age-related macular degeneration. We very much look forward to his talk on these subjects today. Thank you very much for joining us. And I'll just point out that he likes his work so much, he's come to us at 4:30 a.m. California time to join us. And Amandeep is so enraptured, he has also joined us at 4:30 a.m. As he's in Whistler. So welcome, Dr. Saraf.
All right, thank you very much, John. That was very, very nice of you to give the introduction. And as early as it is, I'm still very excited to be here and to see everyone at least virtually for this Grand Rounds presentation. I see that there are 60 participants, so that's a great Grand Rounds attendance, and I appreciate everyone being here. I guess I can share the screen now and get started. And how long is the session? Just for in terms of monitoring my time, should this be like a 30-minute talk, I guess, with discussion afterwards?
Yeah, I mean, we have just under an hour left, and there's often quite a bit of discussion, so in that range would be good.
All right, that's awesome. It's nice not to have to rush. Usually I have to compress these lectures into 6 minutes, and that can be a little bit stressful. So let me share the screen here and get my slides. There you go. Can everyone see my slides? That's awesome. So this is the title that I'll be giving today, Pathways of Fluid Leakage in Macular Disease. And this is an area of interest that we've had now for the last few years that has spawned several publications and has led to a greater understanding of how the fluid dynamics in the retina and the choroid. Here are my disclosures. Here's a summary slide of the talk that I'll be giving today. Fluid, intraretinal fluid, and subretinal fluid is an essential marker of neovascular activity. But we should also understand that there are other pathways of fluid leakage into the retina, including degenerative pathways associated with intraretinal fluid and pathways associated with RPE, or retinal pigment epithelial pump impairment, that can be associated with subretinal fluid. I want to also talk about how the choroid can be an important pathway to consider, and specifically choroidal thickening and leakage due to pachychoroid disease is another route of leakage into the retina that we'll talk about this morning. The biomarkers of, now traditionally fluid has been a tried and true biomarker of neovascular activity in age-related macular degeneration. And whenever we see fluid with OCT, we immediately have an indication that there may be exudation. And specifically, we use intraretinal fluid, subretinal fluid, and sub-RPE fluid, as well as subretinal hyperreflective material as biomarkers to indicate that neovascularization is present in age-related macular degeneration, or that there's an abnormal retinal vascular endothelium, an abnormal inner retinal blood barrier, as can be associated with diabetic retinopathy or diabetic macular edema and retinal vascular occlusion or retinal vein occlusion specifically. So typically when we see fluid, there's a knee-jerk reaction that that neovascularization and exudation is present. In macular degeneration, specifically, we have two forms of neovascularization, actually three forms, type 1, type 2, and type 3 neovascularization. Type 1 and type 2 originate from the choroid, and type 3 originates from the retina. And we can see in these cases the presence of subretinal fluid as an indicator of neovascular activity, as well as intraretinal fluid and a pigment epithelial detachment, in this case associated with type 3 neovascularization. I just want do you guys see this bar that's obstructing my title here? I'm wondering if I can get rid of this somehow.
No, we don't.
You don't see the bar. That's okay then. Let me just go back a slide. All right. So with type 3 neovascularization, we can often see intraretinal and subretinal fluid and sub-RPE fluid in association with the RAP lesion as indicators that there is exudative activity that's originating from this neovascular focus. And we use this as a guide to treat these patients with anti-VEGF therapy and clear these features of exudative activity. And here's an example of a patient with a type 3 neovascular membrane and the associated biomarkers or mediators of exudative activity before and after anti-VEGF therapy. And you can see resolution of the intraretinal and subretinal fluid, as well as resolution of the pigment epithelial detachment, and just a residuum of this neovascular RAP lesion present. And so OCT evidence of fluid can be a very important diagnostic marker and guide to therapy. Here in this patient with type 1 neovascularization, you can see the choroidal neovascular membrane on the OCT angiogram. Again, the mediators of neovascular activity, a pigment epithelial detachment, subretinal fluid that resolves after Eylea injection. Again, showing the importance of the identification of fluid as a mediator of neovascular and exudative activity. Sometimes we don't even see fluid, we can only see SHREM, what we refer to as subretinal hyperreflective material, in this case associated with a neovascular membrane, a type 1 neovascular membrane originating from the choroid. This was the only sign that there was exudative neovascular activity, and so we went ahead and treated this patient with anti-VEGF injection. The SHREM resolved, the neovascular lesion cleared, and the patient had a commensurate significant improvement of visual acuity from 2150 to 2025. In this case, we can again see a pigment epithelial detachment, subretinal fluid, subretinal hyperreflective material, indicators that this patient has an active exudative focus due to a neovascular membrane that we can see here on OCT angiography. We went ahead and injected this patient with a series of Eylea injections. And in this case, there's resolution of the SHREM improvement of the fluid, but some persistent fluid, indicating that perhaps we have persistent neovascular activity that you can appreciate again here on the OCT angiogram, these fine vessels that are noted with en face OCTA. When we have persistent fluid, this is a complication that is not unusual, that we have seen in 25 to 50% of some of the major pivotal clinical trials that have shown persistent fluid can be present at 1 or 2 years. This can be an indicator of continued neovascular activity. And you can see growth of this neovascular membrane, this type 1 neovascular membrane originating from the choroid in association with this persistent or residual fluid. And this can be an indicator that perhaps a stronger anti-VEGF is needed and that there is persistent neovascular activity. In the CAT trial comparing bevacizumab with ranibizumab, we saw that fluid of any type was least in the monthly ranibizumab arm. And so this was an indicator that persistent neovascular activity may be a factor when we see persistent or residual intraretinal or subretinal fluid. In the Hawk and Harrier trials, we also saw that the stronger anti-VEGF agent, brolucizumab, was associated with lower fluid. You can see in the brolucizumab arms in black, there is a greater reduction in retinal thickness versus the aflibercept arm that is dotted. And so the stronger anti-VEGF agent is associated with less fluid. So again, showing that fluid can be a reflection or an indicator of exudative and neovascular activity. And sure enough, in this case presentation, you can see persistent recalcitrant fluid that does not completely clear with aflibercept therapy, but when brolucizumab therapy is instituted, you can see finally resolution of most of that subretinal fluid. So again, indicating that subretinal and intraretinal fluid can be an indicator or a biomarker of neovascular activity. But as I mentioned at the start of the talk, other pathways should be considered when we see fluid. And in the case of intraretinal fluid, we should consider other mechanisms. And those include tractional mechanisms that can lead to fluid, as well as degenerative mechanisms that can lead to fluid in the retina, in the case of intraretinal fluid specifically. And it's very important to understand that atrophy can be associated with intraretinal fluid. And this is a critical concept to recognize so that we don't unnecessarily inject eyes when we see intraretinal fluid that results from degenerative pathways. And Solomon Cohen out of Paris was the first to show these intraretinal pseudocysts that can overlie areas of RPE or atrophy or geographic atrophy. And here in this time-lapse video, you can see this large drusenoid PED that collapses, RPE atrophy ensues, and then the development of these pseudocysts or areas of intraretinal fluid in the middle retina and the internuclear layer. And on the autofluorescence, you can see that evolution from hyperautofluorescent large soft drusen to macular atrophy, or what we refer to on the OCT as C-RORA, complete RPE and outer retinal atrophy. And I'll show you some more examples of these degenerative cysts that can develop. Here again, a drusenoid PED, it collapses, C-RORA or RPE and outer retinal atrophy develop on the OCT. And then you can see these large intraretinal cysts that are very characteristic of a degenerative pathway, not an exudative pathway, and therefore no anti-VEGF therapy is required here. And there's that characteristic area of C-RORA that we refer to, this band of 250 micron band of RPE and outer retinal atrophy that we can recognize on the OCT. Here's another example showing the progressive development of atrophy, in this case that started out as a large drusenoid PED, The PED begins to develop biomarkers of atrophy, such as these intraretinal hyperreflective foci, these areas of RPE thickening, and these hypertransmission bands indicating RPE thinning. The drusenoid PED eventually collapses. You can see migration of those RPE foci, those intraretinal hyperreflective foci. Eventually, the drusenoid PED collapses and resolves, and then you get this hypertransmission band, this area of atrophy, again, that we refer to as C-RORA, and these amazing degenerative cysts that are a sign of degeneration and not exudation. And this is a case, again, that we would just monitor despite the presence of intraretinal fluid. Why do these degenerative cysts develop? Perhaps it is because of the loss of Mueller cells. When retinal atrophy ensues, we lose Mueller cells, which are very important hydrostatic elements that clear fluid out of the retina and into the deep capillary plexus of the retina at the level of the middle retina and the internuclear layer. So when you lose Mueller cells, degenerative cysts in the internuclear layer can develop. And this may be why we see these pseudocysts in areas overlying atrophy. And when I see intraretinal pseudocysts isolated to the middle layer, overlying areas of C-RORA, I just monitor them and I watch for any progression. And typically in non-exudative, non-neovascular pathways, you don't see any progression of that fluid, as in this case, in which we observed over the period of many months to a year, the pseudocysts really don't change very much, and there's no progression of the fluid, which is the opposite of what you see when there's neovascular fluid. The fluid typically progresses. So this can be an important guideline that I use in distinguishing or differentiating neovascular fluid from degenerative fluid, or fluid that is the result of RPE pump failure, which we'll talk about right now. So the other level of fluid to consider is subretinal fluid. And though we mentioned that subretinal fluid can often be a mediator of neovascular pathways, you should consider the non-neovascular mechanisms of subretinal fluid that are very common and can very easily be confused as an indicator for anti-VEGF activity and as an indicator that neovascularization is present. But it is important to appreciate that even in AMD, in both non-neovascular and neovascular AMD, you can see subretinal fluid, and it is probably the result of RPE pump failure. So this is a paper that we published recently in the BJO, in which we captured hundreds of cases, upwards to hundreds of cases of non-neovascular AMD, eyes that had drusen or large drusen or drusenoid PEDs and fluid, but no evidence of neovascularization with confirmation with angiography, fluorescein angiography, and often OCT angiography. And these are three cases of non-neovascular AMD where we can see the three patterns of fluid and no evidence of neovascularization. And often this fluid can be at the apex of a large drusenoid PED or a large drusen, or as a drape, or at the angle, but typically at the apex. And we'll talk about why it develops at the apex. And this fluid often will resolve once our complete RPE atrophy takes place. And so it can actually be a marker that the RPE pump is working, but at a suboptimal rate. And this may be an indicator that the RPE is breaking down. And once it breaks down, then that barrier is lost, the fluid clears into the choroid, and you often will see resolution of the subretinal fluid once complete RPE atrophy takes place, as you can see in these three different cases of non-neovascular fluid in intermediate dry, in quotation marks, dry AMD. Not really dry because there's fluid, but it's not being driven by neovascularization. And this is another example of a case that we included in the study, in which we again can see subretinal fluid associated with this large drusenoid PED, again at the apex. Eventually, this drusenoid PD collapses, atrophy or C-RORA ensues, and the fluid resolves. So why does this fluid develop? Well, as I mentioned, we think it's related to RPE pump failure. We think the RPE is working, but it's stressed, it's overwhelmed, and so fluid accumulates. But it is also an indicator that the RPE may be slowly breaking down. And so often when you see fluid at the apex, it may be a sign that eventually RPE atrophy will take place. And it's interesting that we typically see this fluid in large drusen and in drusenoid PEDs, and typically at the apex, as I mentioned. And we believe the apex may be the indicator of choroidal ischemia. This is the point at which you have the greatest separation from the underlying choroid. And so what happens, the RPE becomes a little ischemic, especially at the apex. That's where we also see the mediators typically of atrophy, such as those intraretinal hyperreflective foci that I pointed out for you. And so when the RPE becomes ischemic at this point where there is greatest separation from the choroid, eventually it starts to break down, fluid accumulates, and at the end of the day, atrophy will set in, the RPE will collapse, and when that barrier and pump is completely gone, the fluid typically washes away into the choroid. So here's another example of a fluid at the apex of a large drusenoid PED. There's no neovascularization. The RPE is working, but it's probably stressed and overwhelmed. Eventually, after several years, it breaks down. Atrophy ensues, C-RORA, and the fluid clears. And this may be why we often see that subretinal fluid has been correlated with better outcomes in neovascular AMD, because it may be a sign that the RPE is still functioning, although albeit at a suboptimal level. It's very important to understand that subretinal fluid is not always a mediator of neovascular activity. We have several patients in our own practice and also referred that have been treated for years with anti-VEGF injections with no evidence of neovascularization. And this is a case that was referred to me. The patient was receiving regular anti-VEGF injections. I saw fluid associated with large drusenoid PED, but no neovascularization on the OCT angiogram. And so what we do now in patients in whom we suspect non-neovascular fluid, perhaps related to RPE pump impairment, we suspend injections and we embark on what we refer to as an observe and extend regimen. And how that works is we stop the injections, we very closely watch the fluid at short intervals. If that fluid continues to remain stable or improve, we begin to enlarge increase the visit interval. And you can see in this patient who had received several anti-VEGF injections, once we stop the interval of injection, the fluid doesn't change with this observe and extend regimen. Now here at several months, I'm now seeing this patient at 6-month intervals, and there's been no change in the fluid. This is in contrast to neovascular fluid, which typically will increase or progress after you stop injections. Here's another example of a patient who I have to kind of embarrassingly note that I was treating this patient for several years because she had these large areas of fluid over these large confluent drusen. But then I would look at the OCTA every month or every several months, and I didn't see any neovascularization. Again, here, several months later, we stopped the injections, still no neovascularization. And I'll show you the time-lapse video once we stopped and started the observe and extend regimen, longer and longer intervals, but the fluid doesn't change. And this is because there's no neovascularization, as we confirm with OCTA, and this fluid is just likely related to RPE pump impairment. And you can see no change. All right, so that's non-neovascular fluid in AMD. In the last 5 to 10 minutes, I wanted to talk about the last pathway of leakage, which is choroidal leakage into the retina. And there are many various diseases that we've studied, including RP, as you can see in these cases, in which choroidal a thickening or pachychoroid disease, what we refer to as a thick choroid or large, thick outer choroidal vessels, can be an important mechanism and pathway to consider when you see intraretinal and subretinal fluid. And in this particular study that Claudio Iovino, who's a very close colleague of mine from Italy, who was a fellow with me for several months, he did this amazing paper when he was with us in LA, in which he looked at the choroid in RP patients with and without intraretinal fluid. And what he wanted to see is, in these RP patients, were they developing fluid in association with a thick choroid? And what he did is he did formal choroidal thickening analysis, what we refer to as the Choroidal Vascular Index, CVI, which is a ratio of the luminal area of the choroid over the total choroidal area. And what he found when he did these choroidal vascular index maps is that he found that both the total choroidal area and the luminal area was greater in patients with RP who had intraretinal fluid versus those patients with RP who had no fluid, indicating that perhaps the choroid was driving fluid into the retina in these patients with RP. You can tell that this patient has a rod cone dystrophy because note the ellipsoid is all gone here outside the center of the macula. And here's another example of two cases of RP in which Claudio did these beautiful choroidal vascular index maps. And you can see in the case with CME, there's a very thick choroid, a larger total choroidal area and luminal area in the RPI with fluid, and no fluid in the RP. And in the eye with no fluid, there is a much thinner choroid with smaller values for the total choroidal area and the luminal area, indicating that the choroid may be a pathway driving fluid in retinitis pigmentosa. Claudio also did a second study, a study in which we recruited cases from all over the world, Europe and Asia, and we did again choroidal vascular index analysis in all our CSR patients who underwent PDT. And here is a case of a patient with a very thick choroid and subretinal fluid. You can see the formal choroidal vascular index analysis here at baseline. And what we found that both after half fluence and half dose PDT, there's a shrinkage of the choroid at 1 and 3 months that is associated with a commensurate resolution of the subretinal fluid, indicating again that the choroid is driving fluid into the retina in CSR, and that PDT can mediate resolution of that fluid. And this is a case of half fluence PDT, where you can see shrinkage of the choroid, a reduction in the choroidal thickness, the total choroidal area, and the luminal choroidal area after half fluence PDT. And in this case, after half dose PDT, again, we can see resolution of the subretinal fluid with a commensurate reduction in choroidal thickness, and as well as a reduction in the total choroidal area and the luminal choroidal area, in this case, after half dose PDT. It's interesting that the Europeans seem to prefer half dose PDT. I tend to gravitate towards half fluence PDT. In our study, we saw that both were associated with reductions in the choroidal area and choroidal thickness, but that the reductions were slightly greater with half dose PDT. This is a recent case that I've been working on actually with the fellows. I'm very excited to show it. I just added this case last night. It's a patient we saw just this week, actually, in whom we see these remarkable increases in the choroid associated with anterior uveitis that was thought to be related to the patient's herpetic infection of the cornea. So whenever this patient gets a herpetic flare-up or evidence of iritis, what we see is that the choroid starts to engorge. And you can see this increase in the choroidal thickness that finally is associated with fluid being driven into the retina, this area of subretinal fluid. And then we start the steroids for the patient's uveitis flare-up. the choroid shrinks and the fluid resolves, again indicating that the choroid is driving fluid into the retina. And if you don't believe me, just look at this chart of this amazing patient who my fellow Ahmad Santina from Lebanon, actually, he charted this. And what he showed, the right eye doesn't have any flares. The left eye is in orange. And the choroidal thickness in orange. So whenever the patient develops a flare in yellow in that left eye, look what the choroid does. It goes up to 400 microns, steroids are started, the choroid goes down. Then there's another flare here, the choroid goes up to close to 450 microns in thickness, steroids are started in green, the thickness reduces. And this is his most recent flare-up in December, off the charts, choroidal thickness over 500, steroid drops are started, and the choroidal thickness precipitously and sharply drops. And that represents this particular interval here that I showed you, where this cord is like a sponge. It just becomes so engorged with the flare-up. Steroids are started, the choroid goes down 3 or 4-fold, and the fluid resolves, indicating that the choroid is a very important pathway of leakage into the retina that should be considered. To finish up, I'll talk about peripapillary pachychoroid syndrome, which is a new disorder that we recently described that's very common. It could probably be alternatively referred to as peripapillary CSR. And these patients get intraretinal fluid typically. They can get subretinal fluid less commonly. And this is driven by peripapillary pachychoroid disease, or these areas of very thick choroid around the nerve, which is actually paradoxical because normally the nasal area of the macula is the area where the choroid is the thinnest. And this is a beautiful case actually that was loaned to us by Pierce Keane out of Moorfields in London, showing this classic pattern of peripapillary pachychoroid syndrome, in which you see this very thick choroid in the nasal macular region that's driving fluid into the retina. And these cases can be very easily confused with uveitis and optic neuropathies because the nerve is often hyperemic because of the peripapillary choroid, which is kind of compressing the nerve. And so they often masquerade these cases of peripapillary pachychoroid syndrome as diseases, inflammatory diseases, or optic nerve diseases. Here's another case of peripapillary pachychoroid syndrome. You can see the peripapillary intraretinal fluid, the thick choroid in the nasal macular region. And typically, as I say, intraretinal fluid is more common. Subretinal fluid is less common unless the fluid is very severe. And it's often bilateral, as you can see in this case. So this was the original paper that our fellow from Thailand described. And these patients, as I noted, have thickening that is predominantly in the nasal choroid around the nerve. Often the fluid is intraretinal, and they have other signs of CSR, such as choroidal folds. And we think that this is just a variant of peripapillary CSR that occurs around the nerve. And I'll show you exactly what's happening in this condition when we get when I show you the ICGA of one of the patients. So this is there are a couple of amazing patients I have with peripapillary pachychoroid syndrome, in which the fluid was so severe that it was driving subretinal fluid into the macula. And here is a case, again, of one of these patients with peripapillary intraretinal fluid, an extremely inordinately thickened choroid that's driving the development of this intraretinal fluid. And there are also chronic changes of outer retinal loss in this case. And here is his left eye, where you can see this massive choroid over 500 microns, causing very severe subretinal and intraretinal fluid that requires treatment. And what we've been, PDT is still considered, I think, an important option that you have. But what we're seeing in some of these cases is that they can resolve dramatically with intravitreal Eylea injection. In this particular case, we always get an OCTA to rule out neovascularization. And you can see in the inner choroidal segmentation slab, there's no neovascularization associated with this retinal fluid in either eye, no neovascularization. And here's an ICGA that is showing you what's happening in these patients with peripapillary pachychoroid syndrome. We believe what's happening is that there's vortex vein obstruction, and so there's choroidal outflow impairment, and this redirects flow to other areas in the posterior pole. And in the case of peripapillary pachychoroid syndrome, there's redirected flow around the nerve. So you often see these large anastomotic vessels around the nerve that have choroidal hyperpermeability. You can see leakage around the nerve and in other areas of the posterior pole in these cases. Again, look at these large dilated vessels around the nerve that have choroidal hyperpermeability. You can see leakage of the ICGA dye. So this redistribution of choroidal flow may be what, because of vortex vein obstruction, may be what's driving fluid leakage into the retina in this peripapillary distribution. And this is the case I wanted to show you, where you can see this remarkable resolution of fluid, peripapillary fluid, as a result of anti-VEGF injection with Eylea. And the time-lapse video that one of our fellows from France put together really illustrates this the best. And this is after we went to monthly injections. You can see this remarkable and dramatic resolution of the peripapillary CME, which was critical because this patient was losing vision because of the chronic fluid, leading to this area of ellipsoid loss that you can see here on the en face OCT. And again, just to validate how these injections reduce fluid and also reduce choroidal thickening. And so here you can see wherever in blue is where we give the anti-VEGF injections. And whenever we give it an anti-VEGF injection, you can see commensurate reduction in choroidal thickness that was associated with that resolution of peripapillary fluid that I showed you on the time-lapse video. And here's his other eye. Again, look at, here's the intraretinal and subretinal fluid to start. With repeated a monthly injection, you can see resolution of the fluid on both the en face OCT and on the cross-sectional OCT. And here's the time-lapse video, really illustrating that dramatic resolution the best associated with the monthly Eylea injections. And then again, the graph that our fellows put together showing you a commensurate reduction in the choroid, indicating that the choroid is driving fluid. When we reduce the choroid with Eylea injections, we reduce choroidal thickening and we resolve the peripapillary intraretinal and subretinal fluid that was occurring in the more severe cases. And this was critical because, as I say, this patient was developing ellipsoid loss associated with that chronic intraretinal fluid. We also discussed laser with him, doing PDT, just because it could be somewhat onerous to do injections on a regular basis like this, but he's adamant to continue the injections, and we've maintained him close to 20/20 vision. So in summary, intraretinal subretinal fluid can be an essential marker of exudative and neovascular activity and represent our gold standard biomarkers of leakage. But we should also consider that these fluid markers can indicate other routes of leakage. Intraretinal fluid can be a sign of Mueller cell loss and degeneration, while subretinal fluid can indicate RPE pump impairment. And in addition, we should also consider the choroid and specifically cases of pachychoroid, which may additionally be driving fluid into and under the retina. Thanks very much for your attention. It was so nice to move at such a comfortable level like that. I appreciate that.
Thank you very much, Dr. Saraf. We have a few questions, and I'm going to lead off with one showing my ignorance since I do cataract refractive. But you showed several slides where the fluid could be from RPE pump failure in the drusenoid PEDs. And had you treated those patients with anti-VEGF injections, they might have just spontaneously resolved anyway, and you would therefore have thought that your treatment had actually worked. So I just wondered if you could comment on that. Presumably, you must need some angiographic evidence before you begin treatment then.
Yeah, that's a very astute question. You should be a retina specialist, I think. So yeah, I think you can get into this cycle where you're injecting for years like we did, because you do often see, as I showed you in the peripapillary pachychoroid cases, you do often see some response, especially to Eylea with injections, and that can give you a false indication that there's neovascular activity. But you have to look for these other clues, and you mentioned one already, angiographic exclusion of neovascularization is an essential clue. And when you don't see neovascularization with OCT angiography, you should start considering that maybe other pathways may be inherent and may be a factor. The other thing to consider is that the situation when you have residual or recalcitrant fluid. So whereas this fluid may improve, often there's residual or persistent fluid when you have these other pathways involved. And that may be another clue that perhaps RPE pump impairment may be a factor. And when I can confirm that there's no angiographic evidence of neovascularization on the OCTA, and I don't see other mediators of neovascular activity such as SHREM or blood, then I might consider doing an observe and extend because of the reasons you suggest with regard to a false sense of comfort that you're seeing response with the anti-VEGF injection. If you can exclude neovascularization and there are no other mediators such as blood, then maybe try and observe and extend, and you'll find in those cases the fluid doesn't typically progress.
So there's a question from the audience that is sort of the reverse of what I just asked. What if you do see evidence of neovascularization? This is from Dr. Michael Brent, evidence of neovascularization on the OCT angiogram, but without any fluid on OCT. How do you manage those patients?
Well, that's a lecture of a completely another kind. And what we refer to that is a non-exudative neovascularization or non-exudative macular neovascularization. And that has actually been more recently, I think, understood better with the advent of OCT angiography. Although in the 90s, the Kerkis group out of Milan showed that neovascularization can be present with ICGA in the absence of fluid. And now with OCTA, we're seeing that phenomenon much more commonly. And the group out of Miami, led by Phil Rosenfeld, were the first to show it with OCTA. And so you can see neovascularization in AMD patients. Often a clue may be what we refer to as a double layer sign, where you see this shallow, irregular RPE elevation, or what we refer to as SIRE on the OCT. And then you get the OCTA, and sure enough, you see a neovascular lesion, a type 1 neovascular lesion under the RPE from the choroid, but no fluid on the entire OCT volume data set. And generally, the thought is that we monitor these patients because there's no fluid, we don't need to treat, but they're at a much greater risk. 20%, I think, is the number that we quote in the first year, but the great majority of these cases, upwards to 100%, eventually develop fluid. And then we monitor them closely, more closely than we would if there was no evidence of neovascularization on the OCTA. And once they develop fluid in association with neovascularization on the OCTA, then we earnestly can start our anti-VEGF therapy. But the short answer to the question, non-exudative neovascularization, you don't need to treat those, just watch them more closely.
David, we published a couple of papers on the use of anti-VEGF for corneal neovascularization. You know, that slow creep that you get with vessels going further and further central onto the cornea, and eventually can result in scarring centrally with loss of vision. And these are difficult grafts because they're vascularized and higher incidence of rejection. What can we learn from our retinal colleagues? Is it sufficient? We published one paper showing subconjunctival Avastin injection does work. And then we did intrastromal plus subconj, and we found that it had a greater effect. Is it sufficient to get the anti-VEGF near the vessels, or do you have to actually cannulate the vessel?
Well, there are several concepts to talk about, and I appreciate this other perspective. That's the benefit of doing a grand rounds like this with all the other subspecialties. The first thing that we understand, I think, that is common to both corneal neovascularization and choroidal neovascularization is that those vessels are a result of ischemia. So presumably there is maybe limbal ischemia, and you see the growth of those vessels trying to reconstitute oxygen supply. And that is inherently what's happening in the retina. The RPE is ischemic, and so we develop choroidal neovascularization to sustain the RPE and the overlying receptors. But the difference is that in the cornea, these vessels can lead to scarring because of the importance of maintaining the cornea as an optical media. It lends itself to scarring from the vessels. But in fact, we now understand in the choroid and the retina that choroidal neovascularization actually benefits the RPE. And it's the secondary exudation and fluid that leads to the vision loss. And then you can get scarring with bleeding, of course. But what we've noticed is that in patients with choroidal neovascularization, often the RPE stays viable, and it may be protective against RPE atrophy. And in fact, we'll see eyes in which there's neovascularization in one eye, no neovascularization in the fellow eye. The fellow eye often progresses to atrophy much faster. And these eyes with non-exudative neovascularization, in fact, we can see them sit for many years without the development of RPE atrophy. And we think that these neovascular lesions actually paradoxically sustain the RPE and recapitulate the choriocapillaris and prevent RPE atrophy. So that aspect is very interesting in contradistinction to the cornea, where those vessels seem to be more damaging. With respect to your question about where to inject, I don't think you need to cannulate the vessels at all. In the case of posterior segment disease, we're just injecting into the vitreous, and still we can see dramatic and remarkable effect of those blood vessels under the RPE in the choroid. And so you don't need a local administration of anti-VEGF. I would expect perhaps you might even see an improvement in the choroidal neovascularization injecting into the vitreous. I would expect to see a response. So there are some issues that overlap and some distinctions between choroidal and corneal neovascularization. That's interesting to conceptualize that.
We've actually seen exactly what you say. We've seen regression of the vessels just by getting it into the stroma, not cannulating the vessel itself. Interesting. Thank you.
My pleasure.
Saraf, your uveitis cases has prompted quite a few questions, so I'll try to go through them one at a time here. The first is from Dr. Lichter. What is the composition of the fluid?
Oh, that remains to be investigated. I think that perhaps when we had we know from our basic medical school teaching that there's a different composition of exudate versus transudate, greater protein composition with exudate, less protein composition with transudate. And perhaps when we have neovascular leakage, that subretinal fluid may have more protein composition than what we see with just RPE pump impairment. And so we have made the, I think, loose connection with exudate versus transudate, exudate representing neovascular disease, transudate representing degenerative or RPE pump impairment pathways. But no one has ever actually, as far as I'm aware, actually looked at the composition of fluid in these different circumstances. But it's nice to conceptualize and to make that connection with exudate versus transudate. That's what kind of got us starting on these studies.
Okay, thank you. And then a follow-up from one of our residents, Ellen. She calls it a nerdy question, but she's in the right place then.
Yeah. With the retina specialist, I don't know about the cataract specialist, but certainly with the retina specialist, the cataract are the cool guys, I think.
We like to think so, but I'm not sure that's true. For choroidal dilation and RP versus uveitis, do you think that the former, so for RP, is due to ischemia, while the latter, uveitis, is due to inflammatory dilation? So do we think there's a different underlying mechanism here?
Yeah, I think that in that case of that iritis, and we've seen it in other situations as well. There certainly may be inflammatory mediators, intraocular inflammatory mediators that are causing vasodilation. Does prostaglandins vasodilate? I think they do, don't they? When we put prostaglandin mediators for glaucoma in the eye, we often see that the eye becomes red. And presumably that's what's happening in these cases where we see the choroid engorge, the eye is hot, the choroidal vessels dilate, and then that leads to the leakage. But I think that in other pathways, such as what I showed you in association with drusen, when you have larger and larger separations of the RPE from the choroid, the RPE probably becomes ischemic, especially at the apex. And that leads to RPE breakdown and impairment and pump failure and ultimately atrophy because of loss of the underlying choroidal supply. So I do think there are different mediators here of leakage, inflammatory versus ischemic versus neovascular, that should be considered.
Thank you.
Not a nerdy question at all.
A question from Dr. Epstein. In the uveitis flare case, were you saying that the choroidal thickness can be reduced with topical prednisolone? Yeah,
it looked like that was the case, didn't it? So another example where we can see a remote effect of the treatment we're giving. We're administering drops and we're seeing the choroid clearly shrink in a reproducible fashion. And that was well demonstrated in that graph that my fellow Ahmad put together, which I thought was really cool.
And then a follow-up.
Although one thing we have to consider, though, that in that particular case, I shouldn't say that it's a direct effect on the choroid. We're reducing inflammation in the eye, and that is reducing mediators of inflammation in the eye, which is then allowing the choroid to shrink and to reduce in size and caliber. So I shouldn't say that the drops are getting back to the choroid, but there is a direct effect on inflammation in the eye, which is having a remote effect on the choroid.
I've never seen so many questions about one case. So this is you've triggered the audience here. So
they love that uveitis case, the iritis. Yeah, I love that too. I was up late last night putting it together. I thought it's really cool.
Well, thank you for doing that because you're up early this morning. And one of our senior residents, Aaron, is asking, so in classic CSR, do you see fluctuating pachychoroidal thickness with flare-ups of the disease?
Yes, I think that is there's a direct association. So as you see, I think that these patients are already predisposed to having a thick choroid, and that may be related to various factors, including vortex obstruction that I showed you with the ICGA. And you often see the eye with fluid has a thick choroid, that in patients with CSR, the choroid is thick in both eyes, even in the fellow eye without fluid, but that the eye with fluid tends to have even a thicker choroid. And with flare-ups, I don't know the specific papers, but I'm quite certain that you would see with flare-ups that the choroid even gets thicker than it was at baseline. And so I think you can see that correlation. And we showed it too with PDT. As the fluid resolves, this is related to choroidal shrinkage. Although it's not a permanent effect, we did see that the choroid does rebound to closer to its baseline thickness status and its baseline choroidal area, although there is that brisk response after the laser, which is associated with resolution of fluid. So you definitely can see these correlations with thickness. The greater the increase in choroidal thickness and choroidal area, the more likely you are to develop fluid and vice versa.
He's got a follow-up here, Aaron does. In patients with CSR, does the choroid become thicker with I'm assuming, systemic corticosteroid use?
Yes, I think, I don't know that, I would expect that the answer to that question is yes. I don't know the specific papers offhand. That might be a nice study to look at the choroid with systemic cortisone use, but I would expect that we do see that in patients who are using systemic systemic cortisone, and we see the development of CSR, there should be a commensurate increase in the choroid, but I'm not sure that study has been done. That's an interesting question. Would be an interesting study too.
And then a question from Man Long, same case. So in the case of uveitis, the choroid was much thinner after each steroid injection in the left eye compared to the right eye. What might be the reason for that? Is it effect of the steroid, the uveitis itself, or something else?
Yeah, I think it's affecting the uveitis itself. Yeah, there's a little bit of a twist of thinking here, because on one hand, I'm telling you systemic steroids for CSR can increase the choroid, which I think it is the case, because we know that nasal inhalants of cortisone and PO prednisone, they are associated with recurrent flare-ups of CSR and subretinal fluid. And I think the assumption is that they are increasing the choroid because that's what's driving fluid. But in this particular case, it's a different pathway we're discussing, and I think it's inflammatory mediated. And I think in that particular case, the patient was developing choroidal vascular engorgement due to uveitis flare-ups that was causing the choroidal vessels to dilate and leak. And when we administered the drops, we were mediating resolution of the inflammation, which was allowing the choroid then to readopt to a lower and more normal choroidal thickness. So I think those are two different pathways we have to consider here in understanding leakage with CSR versus leakage with inflammatory disease.
I want to go back a bit. Dan asks, what slab on the OCTA is best to look for a type 1 CNVM? All
right, that's an excellent question. And there's not a universal answer to that. Typically, we use the interchoroidal slab or the choriocapillaris slab to look for neovascularization, but you have to be flexible. You can't use a consistent segmentation for every case. Often you have to look at different segmentation. So sometimes the outer retinal or the ORC slab, which is referred to by Phil Rosenfeld, can be a good slab to see neovascularization. And that's just a wide slab of the outer retina and the inner choroid. Sometimes you have to segment the RPE, contour the RPE, especially in eyes with pigment epithelial detachments, in order to see the neovascularization. So I use either the outer retina slab, the RPE slab, or the choriocapillaris slab to identify neovascularization. And often I'll check all three slabs in a given case. And that's what makes OCTA a little bit cumbersome, because you can't use a single slab necessarily to find the neovascular focus, unfortunately.
And I got one more for you. Thank you for that. Do you see choroidal thinning with normal aging? And if so, in an elderly person with CSR, can you still see pachychoroid?
Yeah, that's a good question. Very, very, very bright residents asking interesting questions.
Oh, that's one of our retina specialists, Dr. Radha Kohli. I think you know her well.
That's Radha. Yes. Okay, I know
yes.
Radha. That explains why it's such a smart question. So choroidal thickness reduces by 10 microns. I believe the correlation that was done when Rick Spade originally identified EDI, or enhanced diagnostic, the enhanced diagnostic index of OCT to look at the choroid. Those original studies showed a correlation of a 10 micron reduction in the choroid for every year that we age. It could be every 10 years. That would actually make more sense. So the short answer to the question is that yes, the choroid is in a constant flux of thinning as we age. And so you can be fooled in older patients. The choroid may be thinner and still the patient may have pachychoroid disease. So you always have to look at the age and also the myopic status, because that's another association of thin choroid. So sometimes you can even see a thin choroid in a high myope, which may be a factor. And one thing to consider is to look at the Haller vessels in the outer choroid. Sometimes those can be very dilated, even though the overall choroidal thickness is very thin. And so you have to take these other factors into consideration when you're making the diagnosis of pachychoroid disease.
Okay, I think we got to the end of all the uveitis questions there.
Oh, boy, I can't believe I got to do another lecture. I'm not going to make it. I'm breaking down like the RPE already.
All right, John, I'll give it back to you.
Yes, well, thank you very much again. We're going to give you a short break. I think you've got a whopping 9 minutes before you've got to carry on. So you want to get at least a little drink. That was a little wonderful talk, and it generated a lot of interest and a lot of questions. So thank you very much for your early rise today to join us. And it's very nice to see you once again.
Really great to see you guys. I appreciate it very much. Really nice to see your faces. If not in person, at least virtual is a nice substitute.
Fantastic lecture again. Thank you.
Thanks, guys.
Thank you very much.
All right, so I'll see you in 5 minutes. Thank you. I'm going to shut off here, and I'll try to answer some of my chat questions too here.
All right. Have a good day, everyone.